Okay, I'm going to talk about infective endocarditis, what it is, and who it can get it. The infective carditis is an inflammation or infection of the inner layer of the heart, the endo layer of the heart, the inner lining. What happens with endocarditis, and usually it stems from rheumatic carditis. Remember when we talked about rheumatic carditis, that they may have issues from then on and they would need to take prophylactic antibiotics if they had any kind of invasive procedures, because it's so easy for them to set up an infection. And where that can happen is in the inner lining of their heart. So because of that, these patients can end up with infective carditis. What really happens is that once the bacteria or the microorganism, whatever that microorganism is, which the two most common ones are strep and staph, that does cause this, but it gets in these valves, and usually the mitral valve, and it tends to vegetate. And what it means by vegetating is that once that microorganism gets into the valve, the body suddenly knows that there is something there that it needs to fight off. So it's going to send fibrin, it's going to send thrombi all to that area, just like it would in any place of the body. And it's going to, but what happens is it tends to get into that valve, get into pockets of it, and just vegetate in one layer over the other, and it forms pockets, gets all lodged in there. And without a valve repair, or they go in and repair it or replace it, then this can be a lifelong problem. So an impaired valve, in other words, a valve that's not working well, can certainly cause an emboli. And emboli can cause a lot of different infarcts to all different parts of the body, stroke, MI. These patients tend to have heart failure as well, because the heart is just not able to push out the blood like it would with a normal, healthy heart. So heart failure tends to be a part of that as well. IV drug users get it. Anyone, say, with that have PICC lines or central casts, especially for long periods of time. Even patients, older patients, immunocompromised patients that have Foley catheters. What happens is, if there's a higher incidence of microorganisms floating in the body, there's just a higher incidence for it to get to the heart, get to the valve, and cause this endocarditis. Most definitely structural cardiac defects can cause that as well. And we talked about the rheumatic carditis. And if that's been a past issue for them, it will make them certainly very prone to this. Valve replacements also, and dental procedures. So the signs and symptoms will always start out usually being that it's an inflammation. They'll have fever, possibly chills. Most definitely they will feel bad. They will not know whether or not they are coming down with the flu, because they certainly won't go, oh, I have an inflammation in the endo lining of my heart. But, they'll be having symptoms like they would if they had the flu. They'll feel bad, they'll have malaise, fatigue, they won't want to eat. Pretty soon afterwards, they will start getting murmurs in their valve. They will start getting an S3, S4. Heart failure is, like I said, is something that will come on about after they have it a while. Most certainly can throw an emboli from that impaired valve, which can lead to a splenic infarction or neurological changes for strokes and things. They can get petechiae, which is just a real fine rash on the body. They can get what they call splinter hemorrhages. I've got a picture on my next slide. It looks like little black lines on the fingernails, Osler nodes, which are painful nodes on the fingers and toes. and some may get subconjunctival hemorrhage. This is on page 763 and 765, so go to your Iggy book and read that. This is the picture. You've got the variant murmurs. You've got cardiac failure. You can the blood can back up and cause some hematuria, especially if they have that infarct to the renal kidneys. They can have that. These are those Osler modes that we talked about, those nodes on their fingers and toes. The petechiae. Here's your splinter hemorrhages. These look more red. And that's fine. They had a nail fold infarct here where a little emboli traveled. They can have, with long-standing endocarditis, they can have some spleen problems, and also what they call raw spots. Raw spots are like white areas back in the retina, and you can see that on ophthalmoscope. And with the emboli, you can also have cerebral stroke or there as well. So we want to diagnose them, and we will diagnose them with a positive blood culture. So remember, those where we go and stick their vein. Usually it comes in like little small jars, or it's a lot bigger than just a syringe. And you would draw those blood cultures. You have to draw in two different places. So you can't draw up the two vials in the same stick. You have to stick and then draw a vial and then stick and draw another vial. Then you send that off to the lab, and in about 72 hours you'll get a really good report to show what kind of organism is floating, so we'll know what kind of antibiotics to treat this with. This diagnosis is very, very difficult to treat with antibiotics, and we'll talk about that in the treatment. They will get a regurgitate type murmur, and they will see this involvement on like an echocardiogram or a transesophageal echocardiogram. That's when they just take a scope and put it down, and they can do an echocardiogram. They put it down their throat and down their esophagus, and they can see better than they can on the outside of the chest. They may get, they will be anemic. They can get anemic with a low H&H, and you will see an increased white blood cell count as well. Now, we will be giving these patients antimicrobials, and that's antibiotics. And it will be very, very high doses of that because, if you're giving IV antibiotics and you're sticking a vein, it's going to go throughout the whole body. Then it's going to eventually get to the heart. So it will have lost a lot of its potency before it ever gets there. So that's one reason why it's very, very hard to treat with microbials, but that is the treatment for it. What they'll be doing is giving much higher doses for a very extended length of time. So all the little symptoms they may get from high doses of different types of antimicrobials like diarrhea and all, they may suffer from that. So you might have to really be on your toes on trying to prevent all these things from happening. Most definitely with these patients, they need to have rest. They need to have rest, especially balanced with activity, supportive therapy with heart failure, orthopnea type symptoms, so sitting up, many rest breaks, those kinds of things. So the surgical management may be valve replacement or even going in and draining the abscess so that they can get a good handle with the antibiotics. Another reason why the antibiotics, not only is it just go out throughout the whole body before it gets to the heart, those vegetative pockets that we were talking about, sometimes it's very hard for the antibiotics to reach that and to get into it, especially if it doesn't have a lot of good blood supply there. Because of all the vegetation, So that's why it's just so very difficult to treat these people. The nursing management, these patients will be a lifelong problem for them. They will probably go home on antibiotics. They most certainly, the doctor may have them come in periodically throughout their life and give them a round of antibiotics just to make sure that, you know, there's not any buildup of microorganisms in those areas. And, you know, so they may do that. They certainly going to have to do prophylactic antibiotics before any kind of invasive procedure, especially even dental procedures. So we want to teach the client IV antibiotic administration in the home and collaborate with the home care nurse for that, especially for the hospital nurse, sending them over to the home care. So we want to make sure that we have good continuum of care with them going from one area to the other. We want to teach care of the PICC line and the central cath and try to minimize any type of microorganisms there by fastidiously doing dressing changes and hand washing properly. We want to teach them proper oral hygiene with a very soft toothbrush. We don't want to, you know, make any kind of openings in the skin with a hard toothbrush. And they need good mouth care. We're not going to use floss because that can certainly cut the skin and cause a microorganism to get into the bloodstream, or even that irrigation device like the toothpicks and things. Teach client to clean and open skin areas well and apply antibiotic ointment, and teach client to request prophylactic antibiotics for any invasive procedure. And to report any fever, chills, malaise, weight loss, or gain, fatigue, or dyspnea. Because once they start having that, that is a sign that could be getting some endocarditis. So they need to be checked out thoroughly for that. And that is the end of infective carditis. Thank you.